Okay, so this is part two of the blood pressure lecture. And so this is a PowerPoint that's posted to Moodle, and it's blood pressure part two is what it's called. And this just has a few additional pieces of information in it that I wanted to make sure that we talked about. So we're talking about blood pressure, and we were talking about how the body determines where blood is going to be routed to, okay, depending on what you're doing, what activities you're currently engaged in, and whether we've got sympathetic dominating or parasympathetic dominating. So during exercise, we have a different distribution of blood going to tissues in the body. And so what do we see with this? And what we've done is they've kind of broken down to different areas of the body and what happens when we're exercising. So blood traveling to the heart is going to increase during exercise in order to meet the demand for increased cardiac output. Typically, what we see with the brain is that blood flow to the brain doesn't really change. It's fairly consistent. We always want to have adequate perfusion to our brain. And so no matter what we're doing, blood flow to the brain pretty much stays the same. What happens to blood flow to the kidneys? So think about it. If you are exercising or otherwise activating your sympathetic nervous system, is it really important at that point in time to flood the kidneys with blood so that we can sustain the process of filtration and urination and all that? It really isn't. So we kind of put that on hold. So a lot of times what you'll see is blood flow to the kidneys is going to decrease. What happens to the skin? Well, you can see this if you've ever done hot yoga and you know that you turn bright red. Well, obviously blood flow to the skin at that point has increased because you have to get rid of all that extra body heat. Same thing happens when you run hill repeats or do any kind of exercise. Blood flow to the gut, so intestines and liver, what happens? It's not that important at that point in time to be digesting that Chinese super buffet, so we're going to decrease blood flow to the gut. What happens to blood flow to the skeletal muscles? Well, this is where all the magic's happening, right? So we want to increase blood flow to the skeletal muscles to help support their demand for activity. Okay, so that's how we regulate it. So what ends up happening is we end up changing blood flow to different areas of the body based on what we need. So this kind of says the same thing, it's just in a little different format. So blood flow to the brain remains pretty constant, right? Doesn't really change much. But blood flow to some of the other structures is actually going to increase. Look at skeletal muscles. This is out of our total blood flow. Going from 12,000 liters per minute up to, 1,200 liters per minute up to 12,500 liters per minute, milliliters per minute. Basically increasing blood flow to the skeletal muscles as we're exercising. What happens to blood flow to the skin, going from 500 milliliters per minute up to 1,900 milliliters per minute, so increasing there. So blood flow to various organs and tissues are going to be specifically suited to needs at that particular point in time based on what we're doing. How does our body know how to do this? How do we know? How do we know where to send blood? So that's really important. We do this a couple different ways, and this gets fairly complicated, and I think in the grand scheme of things, I just want to point out some highlights with this. So basically, we can control blood flow to certain areas through this process called autoregulation. And what autoregulation does is it creates these different factors to facilitate blood flowing more to one area and less to another. Okay, so this is kind of how we override that total body vasoconstriction that we have with sympathetic nervous system activation. Okay, so when we activate our sympathetic nervous system, we are going to create vasoconstriction. But we don't want to vasoconstrict blood flow to every part of our body because some parts of our body really need it. So we are able to kind of override that vasoconstriction. So I think these are important. I'm just going to pull out a couple interesting parts here. One is the fact that we can have these metabolic or chemical factors that override vasoconstriction. So if you have working muscle, and if blood flow to that working muscle, to like the skeletal muscles of your legs, is not meeting the metabolic demand of those muscles at that point in time, we have decreasing oxygen levels because we don't have enough blood flow to those working muscles, and we see an increase in hydrogen ion buildup and carbon dioxide buildup. That's going to end up creating a relaxation of the smooth muscle of the blood vessels, resulting in vasodilation, which then results in increased blood flow to those working muscles. Okay? And so this is how your body is going to route blood flow to working areas of the body and away from areas like the kidneys who don't need it as much at that point in time. Another factor here too, and I like to bring this up, is nitric oxide. Nitric oxide is a potent vasodilator. And so this is one of those substances that you see a lot of times in supplements that people take before they work out. And this is why. In our body, we naturally have nitric oxide. It's released by the endothelial cells lining our blood vessels. And it's a potent vasodilator. So when we need more blood flowing to a particular area, those blood vessels are going to release nitric oxide to vasodilate those particular areas to increase blood flow going to them. Okay, so big picture, with both of these scenarios, we are creating vasodilation to override sympathetic vasoconstriction to allow increased blood flow going to particular areas that need it at that point in time. Okay, aside from that, I think we're going to just kind of travel through some of these. This actually is really nice because this is exactly what we just talked about, how we can, in exercising skeletal muscle, as a result of decreasing oxygen, increased carbon dioxide, and increased hydrogen, create vasodilation to ultimately increase blood flow to those particular working muscles. Okay, and that's basically what we just talked about. I'm actually just gonna skip forward here. I talked a little bit about high blood pressure on our last PowerPoint, but here are some updated blood pressure guidelines from the American Heart Association that I wanted to make sure that I posted. And if you look here, here's our, elevated blood pressure now is considered to be a systolic of 120 to 129. And that's something that, your physician would key in on and really watch. Diastolic, if you look here, here's our stage 1 hypertension. A diastolic pressure of 80 to 89 millimeters of mercury and a systolic of 130 to 139 would be considered stage 1 hypertension. So they've actually, we kind of give this 140 over 90 as our beginning stage of hypertension, but actually it's a little bit lower than that. So they brought the bar down a little bit in terms of hypertension. So causes of hypertension, we've got a couple. Primary hypertension is also called essential hypertension. And this is basically about 90% of people with hypertension have primary hypertension. And what we see here is that these patients basically don't have one specific cause. It's a combination of a lot of different factors. So whether it's genetic or environmental factors in terms of diet or smoking or that sort of thing. Here's all your risk factors through here that lead to primary hypertension. The other 10% of hypertension is what's called secondary hypertension. And so this is when you have hypertension that is related to a very specific identifiable cause. So these are patients who have kidney disease or renal artery stenosis, like a narrowing of their renal artery, or they have a specific endocrine disorder that results in a hormone imbalance that leads to hypertension. So these are patients that have a specific medical cause that causes them to have hypertension. It's not due to genetic or environmental factors. And then the last thing is, this is kind of interesting, and this is something that you see when you work with patients. This is called orthostatic hypotension, and hypo means low, right? And so this is what happens when you have patients who come in, and because of postural changes, so maybe they've been laying in bed for like 8 hours, and you go to say, hey, let's take a walk down the hospital hallway, and they go to sit up, and their blood basically pools in their feet, and it takes it a little longer to get back up to their head. These patients oftentimes will complain of dizziness or lightheadedness because their brain for a minute or two doesn't get adequate blood flow. So not great, especially if you have someone who just came out of surgery, so you might want them to sit for just a few minutes until they stand up because they'd be at risk for falling. If they stand up too quickly. This may also be why if you have grandparents who stand up too quickly and they go, whoa, I stand up too fast, it makes my head dizzy. This is what it is, orthostatic hypotension. And so when we measure this in the clinic, what we see is a drop of more than 20 millimeters of mercury in their systolic blood pressure, or a drop of more than 10 millimeters of mercury in their diastolic pressure when they transition from sitting or lying down in bed up to standing. That's commonly when we see this happen. This is showing you the change in position. And what we see with some patients is that this is more common if they're on certain types of medications. So diuretics, will tend to cause this to happen, as well as some patients are on calcium channel blockers for their heart, and that can create a scenario of orthostatic hypotension as well. But kind of some clinical application to this. Thought that was interesting. All right, thank you.